Okay, can everybody see the slide and hear me? Okay. Okay, so we'll be talking about adult ADHD, attention deficit hyperactivity disorder. Now, at the risk of sounding redundant, we're not going to go too much into detail about the fact that it is a quote-unquote childhood diagnosis. So there will be basics enough to make this an all-inclusive, thorough presentation, but not so much the information we already know about child ADHD or children's ADHD. Okay. For the objectives, we'll talk about features, prevalence, epidemiology. We'll talk briefly about the diagnostic criteria, both from the DSM-IV and DSM-V. Many similarities with just a few tweaks here and there. Pathogenesis, associations, differential diagnoses, screening tools, and finally diagnosis and treatment. So the basics of adult ADHD. All in all, an imbalance of chemical messengers in the brain that results in certain difficulties. Difficulties in focus, organizing and prioritizing work, filtering out or ignoring distractions, thinking before action, delaying gratification, extreme restlessness or fidgetiness, poor anger control, difficulty keeping jobs, and obviously marital problems and relationship issues. Nice chart that kind of goes into everything, as well as certain criteria that the DSM-IV goes more specific into when deciding on the diagnosis for ADHD. We see impulsivity, and this includes experiences difficulty waiting for his or her turn, having trouble waiting until a question is finished before blurting out the answer, and often interrupts others. Then there's the inattention. Over here, we'll see that they are easily distracted, have trouble following directions or finishing tasks, have problems with organization, difficulty in listening, especially while others are speaking to them, forgetting about daily activities, losing things, and have tendencies to daydream. And finally, hyperactivity, where you'll have squirming or fidgeting when told to be seated. They're unable to stay seated, so always kind of on the go, having trouble playing quietly, restlessness, always on the move, and talking excessively. So quickly, we'll go into the criteria. So that as per the DSM-IV criteria, 6 or more of the following symptoms of inattention or hyperactivity. Symptoms cause impairment before the age of 7. Over here it says now age 12 because that was one of the changes brought forth by the DSM-V criteria. There should be a significant impairment at 2 or more settings, such as work, school, and or home. And the diagnosis is made once other medical conditions and psychiatric conditions or issues with substance abuse have been ruled out. The criticism here is that, this criteria has not really been validated in adults. It doesn't include developmentally appropriate symptoms for adults. It doesn't identify some significantly impaired adults who would benefit from treatment. And the subtlety and subjectivity of the symptoms in adults and the absence of a single gold standard for confirming the diagnosis makes assessment of ADHD, especially in patients who come later in life, challenging. So changes in the criteria, so raising the required age of onset from 7 to 12. And this could be for a number of reasons, but recalling the age of onset is an issue, especially if symptoms were overlooked or they just didn't seek treatment as kids. And this ultimately may lead to higher prevalence as they have been overlooked in the past, but the criteria must be followed for an accurate diagnosis. Inclusion of examples of how symptoms might be observed in older adolescents and adults. So this lessened the criteria of symptoms for the diagnosis. Some studies indicate milder symptoms than from childhood in those with adult type ADD. And then word changes clarifying quote unquote impairment. And this, I don't think there's a slide on this, but there's a perceived impairment versus an actual impairment. Perceived impairment, for example, a single mom who's having trouble doing her job properly because she's got 3 kids at home who need to be looked after, picked up from school. So if she's unable to kind of keep on task because of all these responsibilities, that could be a perceived impairment versus, she's not performing well at work, because of certain things. For example, she's not able to remain organized in her activities or assignments. And as a result, she's been fired, hasn't been able to keep a job, or marital troubles or relationship issues where, every person she has tried having a relationship with, she just was not able to. So that would be an actual impairment versus a perceived. So inattention. So we have frequent careless mistakes, poor attention to details, does not listen when spoken to, doesn't follow through on instructions, and fails to finish schoolwork or work-related assignments. So in the workplace, not due to oppositional behavior or failure to understand the instructions. And also will have trouble organizing activities. Hyperactivity. Fidgets with the hands or feet or squirms in their seat. Gets up from the seat frequently. Restless, constantly moving. Has trouble playing or doing leisure activities quietly. Often on the go or acts as if driven by a motor. Talking excessively. Impulsivity. Blurts out answers before questions have been finished. Trouble waiting one's turn. Interrupts or intrudes on others or butting into conversations that didn't involve them in the first place. So differences in adult ADHD. The core feature is dysregulation, whether it's emotional dysregulation, et cetera, The feelings of restlessness and difficulty relaxing are seen, as opposed to the quote-unquote hyperactive part of the criteria. Feelings of being on the go all the time. Often their desk is cluttered and things are frequently lost. Many projects are started and worked hard on, but then abandoned before any one of those tasks are completed. Frequently, they would come not only late to appointments, but sometimes early or on the wrong day altogether. Frequent comorbid substance abuse and psychiatric diagnoses also need to be taken into consideration. The consequences of untreated adult ADHD. Patients are more than twice as likely to have been arrested, 78% more likely to be addicted to tobacco, twice as likely to have been divorced, more than twice as likely to have dropped out of high school, and twice as likely to have held 6 or more jobs in the past 10 years. And that's pretty significant. This is just a graphic representation of all the features you might see, as we go down. So starting at children, they'll have academic limitations, possibly issues with relationships. And then as we kind of go down and focus on the adolescents, this is where the smoking and substance abuse, increased rate of motor vehicle accidents, legal difficulties, and occupational or vocational issues as well. There was a graph here, but oh, there we go. Okay. So increased traffic violations and motor vehicle accidents in adolescents and adults with ADHD. So as we can see, those who have the diagnosis of ADHD, significantly higher in traffic violations, speeding, drunk driving, license suspension, as well as driver-caused accidents. Increased lifetime substance abuse, also significantly higher when compared to the control. Okay, so epidemiology and prevalence. So given that they were diagnosed in childhood appropriately, before the age of 12, childhood ADHD continues into adult life at a 10 to 66% frequency. Yeah, this is quite a big range depending on what study. Initially when I had presented this, the research was on average around 50 or 54%. This was about 7 years ago. So different studies have yielded different numbers. The estimated prevalence of adults aged 18 to 44 years with a current diagnosis of ADHD, it was 4.4%. Prevalence being higher for males versus females, and the non-Hispanic white group had a higher prevalence than all other race or ethnic groups. The estimated lifetime prevalence of ADHD in US aged adults between the ages of 18 to 44 was about 8%. This research is from 2001 to 2003, So pathogenesis. So this is related to the noradrenergic system, and this deals with the brain chemical norepinephrine, and it helps in regulating attention, alertness, and executive function. all of which are declined in ADHD or ADHD patients. We'll see decreased dopamine levels and increased norepinephrine levels. The dopamine DRD4, it's one of the genes that is associated with short-term memory and attention span. So a couple slides down there will be a slide that goes over different genes that might be involved in the pathogenesis. So brain imaging and ADHD. So the caudate nucleus and the globus pallidus, the striatum, which contain a high density of dopamine receptors, are found to be smaller in the ADHD population than in control groups. ADHD groups also have a smaller, they have smaller occipital lobes, which are towards the back of the brain. And then areas involved in coordinating activities of multiple brain regions, such as rostrum and splenium of the corpus callosum and cerebellar vermis, are smaller in ADHD patients. There's another graphical representation, size reduction in the frontal lobe, temporal lobe size reduction as well, and then more gray matter in the temporal lobe in patients with ADHD. So there's a genetic predisposition, some strong family history as well. Parents are more likely to have, I got that wrong. Kids are more likely to have it if their parents have it or somebody in their family does. Several genes that have been mentioned in studies, there's the dopamine transporter genes, the DRD4, which we mentioned, dopamine beta hydroxylase, monoamine oxidase, catecholamine methyltransferase, serotonin transporter promoter, 5-hydroxytryptamine 2A, and then 5-hydroxytryptamine 1B. So adult ADHD is more difficult to recognize, which is why many adults remain undiagnosed. The core impairments of the condition, such as inattention, hyperactivity, and impulsivity, remain the same, but usually it's the presentation of the symptoms that make it a little bit harder to recognize. Whereas in children, we'll have hyperactivity, not sitting still, always on the go, climbing or running at inappropriate times. In adults, we'll see more so the restlessness, where they can't stay focused on one thing, or they might be fidgety or impatient. In kids, we'll see physical impulsivity, where they're doing things that might result in increased injuries, having problems waiting for their turn. And in adults, we'll see them with more so verbal impulsivity, where they can say the wrong thing, interrupt others, or speak out of turn. And this we see both ways in both kids and adults. The inattention portion, where they can't pay close attention in class or complete their schoolwork, whereas adults will have difficulty concentrating at work and finishing tasks. For the difficulty in diagnosis, again, there's a lack of guidelines for primary care providers, lack of objectively verifiable tests. The diagnostic criteria are structured more towards making a diagnosis in childhood. There's a high rate of media attention predisposing adults towards self-diagnoses. One perfect example I came across, if you Google, how can I, fake the symptoms of ADHD to get stimulants prescribed for me? Yeah, there's a pretty detailed and pretty thorough set of guidelines, which will pretty much train anybody what to say in terms of, being positive for meeting the criteria for diagnoses. Common comorbidities and concern of stimulants being scheduled to drugs. So there's a possibility of abuse. Maybe they're just doing it to get stimulants. So much of the diagnosis is by clinical interview and therefore involves a fair number of conditions to rule out first. ADHD handouts can be given, which is helpful in screening but not diagnosis because of the 40% false positive rate. Developmental history from multiple sources is very helpful. Assessment of impact on work, study, relationships is critical more than a list of symptoms. And of course, doing a urine tox to make sure they have nothing else in their system, which could be contributing to their symptoms. So the screening tools, there's 3 that I mentioned. There's the Adult ADHD Self-Report Scale. It's a current symptom checklist based on frequency. 18 items are pulled from the DSM-IV, and it's shown to be pretty effective in the primary care settings. Then there's the Connors Adult ADHD Rating Scale. and it's long, 66 questions, costly, and self-report and observer report is pretty time-consuming. Finally, there's the Wonder Utah Rating Scale, and this helps to establish the diagnosis in childhood. 61 questions, adult patient recalls their childhood behavior. It's free and available online. And this is just one example of the adult self-report scale. And the second part of the screen. So differential diagnoses, besides malingering, there are a number of conditions that get confused as ADHD and would need to get ruled out. Substance abuse, especially marijuana use, which definitely affects short-term memory. So if they're having trouble remembering something, making sure that they're not under the influence of marijuana. Bipolar disorder, depression, PTSD, anxiety, personality disorders, ASPDs, antisocial, and then borderline personality disorder, and other medical conditions. And I know we are pressed for time, so I'm gonna kind of fly by these. So bipolar, so certain parts of, especially in the manic phase of bipolar, we will see a decreased need for sleep, increased goal-directed activity, racing thoughts, jumping from one thing to another. So this can easily be confused with the symptoms of ADHD. Stimulants will worsen mania and psychosis, so use it with extreme caution if you do decide to. Thinking, or if you have strong notion to feel that they have ADHD. So depression, PTSD, anxiety. Obviously, the CIGI-CAPS criteria for depression, attention deficit, that is, or lack of attention, that is one of the criteria for depression. So we have to make sure that it's not due to depression that they're having these symptoms, which might easily be confused with ADHD. Patients with PTSD can be easily triggered and switch from activity to activities just so they don't have to relive that certain traumatic experience or something that gives them the flashback of that traumatic experience. And then generalized anxiety, chronic worry, which will, of course, be distracting. Emotional dysregulation and personality disorders. There might be some overlap, but usually personality disorders triggered by a real or imagined abandonment or interpersonal conflict. And this one is particular to the borderline personality disorder. So differential diagnoses that would need to be ruled out: thyroid issues, seizures, especially if you feel that they're zoned out or daydreaming, we want to make sure that it's not an absent seizure. Hearing deficits or ear infections, liver disease, lead toxicity, sleep apnea, drug-induced inattentional syndrome, head injury, and I wrote hepatic disease twice, lead toxicity, and narcolepsy. So those we definitely need to rule out. Again, being pressed for time, treatment, especially for the adults that you feel need treatment, stimulants is the way to go. Of course, do your drug testing first, because it is a Schedule II, can only be given in 30-day scripts. And I'm just going to fly by the stimulant section because I believe that's coming to the end. So Adderall is one of the main stimulants. Then there is methylphenidate, Ritalin, and now the non-controlled Strattera. Not going to go over the dosing just yet. So if somebody has a history of substance abuse, this would be ideal as it's not controlled. Of course, if somebody has their mind made up and that only stimulants will work, they will find this ineffective and unhelpful. And typically stimulants do show a better effectiveness in symptom control. Wellbutrin or bupropion has some efficacy, as do the tricyclics. And they say this is due to the norepinephrine effects. SSRIs are rarely helpful for symptoms of ADD. There's also psychosocial treatment, psychoeducation, educating the patient on their diagnosis, psychotherapy, whether it's individualized or group, behavioral or self-management skills through CBT, skill building and planning and organization, and then couples counseling, marriage, family, career, coaching to kind of help their interpersonal relationships. So conclusions, diagnosis of ADHD requires a thoughtful history taking and clinical judgment, as well as ruling out other possibilities. Treatment can be very helpful to some, but making sure you treat the other diagnoses first. Abuse of stimulants is at a very high level, mostly on college campuses and screening tests can be faked. Watch for mania and psychoses, which will worsen on amphetamines. Any questions?